few announcements before we call roll. In front of me, they gave me a little cheat sheet here. It says, please be aware that this meeting is being recorded and live streamed on LRC's YouTube channel. Our IT staff will mute audio and video where necessary to ensure the quality of our recording the live stream. So for those who are attending virtually, please make sure that you are not streaming the meeting on more than one device in the room you are in, because multiple devices produce a lot of feedback. Please mute your microphone when you are not speaking to avoid background noise, and make sure to turn on your microphone when you are recognized to speak. And please use the chat feature to notify staff if you wish to be recognized for a question or a comment. So in order to do accurate travel vouchers, if you are attending virtually, you should have received an email with your travel voucher attached. Please complete the voucher and email it back to Hillary as soon as possible. And if you have any questions, contact her as well. If you are attending in person, you should receive a travel voucher on your desk, and please return that to staff before you leave today. Our meeting must adjourn no later than 2:30 so that staff can sanitize and prepare the room for another meeting at 3 o'clock. So all presenters were notified in advance that prepared comments should be limited to 15 minutes per presentation, and please be cognizant of this time limit so that we can hear from everybody today. And with that being said, I think those are all of our housekeeping items, and I would like it if the secretary would please call the roll. Senator Parrott.
Here, at home.
Thank you. Representative Bojanowski.
Here in Frankfurt.
David Allgood. Leanne Creech.
I was here. Sorry, I tried to unmute. I apologize. David Allgood is here.
Thank you.
Leanne Creech is here.
Thomas Loreno. Lisa Lee. Brad Schneider.
Present, virtually.
Steve Shannon.
Here in the room.
Amy Stade.
I am here and I am at home.
Yes, I'm here from
Brenda Wiley.
Here virtually.
Senator Adams. Representative Riley.
I'm here.
Here we are. Okay, let's go ahead and get started. I have a few opening remarks, and that is I'm really excited about this task force. I think that there are some real opportunities here for us to get a few things right and to do filled with the level of excitement from people who are on this task force as well. So I'm really looking forward to making some good progress. Let's go ahead and dive in. Presenters, and also I think staff here will go through and do your slides for you depending on what you have sent in. So please.
One of the problems that I see with the waiver is the transportation part of it is a little bit of it makes it hard for some people to get transport, especially in rural areas. So I think there needs to be a better way to get people transported. And then when it comes to part of the waiver, there needs to be the time when it comes to having someone come in to do a catheter for a client. I know right now the waiver only approves every 6 months, but for somebody that needs it on a daily basis, I think it needs to be approved, like yearly instead of every 6 months. Brandon, if you would like to speak on other parts of this, you're welcome to.
Griffith, I'm attending virtually, and I'm a provider of service, but I also help with the local self-advocacy group, which Chris is a president of, and he had asked for my assistance in kind of helping with this. So what I'm talking about is based off conversations that me and him and Shauna have had. So relative to the transportation issue that Chris first brought up, what we had discussed was in the context of Kentucky's transportation services right now are pretty rough for people with disabilities. Essentially what Kentucky has done is created a mass segregated transportation system where people are forced to remain on vans with other participants for sometimes hours at a time. Sometimes staff in this are providing that service, which is classified as non-emergency medical transportation, are not adequately trained to handle crises, and the system should probably be examined. One thing that Chris and I and Shauna had discussed for this group to maybe potentially look at exceptional supports being examined to include a transportation piece so that people can access additional funding for transportation needs. And relative to the second point that Chris just made, and Shauna, if you're on here, Shauna can speak to this kind of directly if she's been able to log in.
Yeah, I'm here.
Okay, so exceptional supports are not indicated to be long-term funding. However, many participants need ongoing enhanced funding. The most impactful of that we could think of was medical exceptional support needs, which would require, in many instances, long-term supports to be in place. So right now in Kentucky, one thing that should be examined or looked at, and this it potentially relates to the exceptional supports protocols, is that people with intellectual disabilities are essentially being funneled into nursing homes in a large amount or other inappropriate settings simply due to having a feeding tube or a peg tube because providers are not able to provide that level of care. However, this is easily done with additional funding where there could be long-term financial support in place so people can access qualified personnel. For example, we talk about catheter care, which Chris mentioned, insulin injections, G-tube feeding, things like that. Right now, and Shauna, again, I want you to speak to this directly. You know, Shauna needs intense medical supports. And so she's operating under exceptional supports to have someone come in and do a skilled procedure. The only funding mechanism for that is under exceptional supports, and this is something that she's going to need for probably the duration of her life. However, we have to go in and do 6-month authorizations at a time, and it does present a certain amount of anxiety for Shauna, not knowing that those things are going to be in place long-term because they have to be reauthorized. And exceptional supports, by design in Kentucky, are not instilled to be long-term mechanism. And so it prohibits people. In her instance, exceptional supports pays for a LPN to come into her home that's contracted through her residential agency. And that's the only way that's able to exist because there's no funding for nursing care in waivers. And providers are not required to have nursing. And they basically operate underneath, unlicensed professionals. So the only way that those things can happen is if an LPN is contracted with to come in. And providers have to have funding for that. Otherwise, it amounts to, in her instance, $75 a day in additional care that is going to have to go long-term. And Shauna, you can speak to that.
Yeah, and also, I'm sorry if I'm echoing. But also with that, level 2 for people, that don't really require a certain amount of funds. There are not accessible homes out there, and it's hard to find supports for those that account for being to live on their own. And the irrigation me because I'm always worried of put in the hospital because I'm not get my catheter irrigated. That's happened several. Brandon, if you want to try.
Yeah, I think the only one we haven't heard from yet is Nicole Griffith. Do we have more, do you all want to discuss more than just the transportation challenges that you find? Is there more to the presentation, or are we focusing on the transportation challenges?
There are, like here in Fayette County, that's and it only into Fayette County. It doesn't take you to go look for county. And for a lot of us who are in advocacy and who can join the conferences, that is to find a way to get to where these meetings are. That's
Is this a good time?
To speak to what she was saying a minute ago, the four of us are presenting, and I help kind of facilitate it with Brandon. I don't know if that's the same.
Just a sentence. Can I ask a question on the transportation?
I'm getting a lot of feedback. I'm trying to determine what is happening right now and who is speaking. Should have it on. Okay. So in this first section, we've heard so far from Chris, we've heard from Brandon, and we've heard from Shauna. We have not yet heard from Nicole, and so I'm looking forward if Nicole has anything to add. But while Nicole is getting ready to speak, can we please have Chris, Shauna, and Brandon mute their microphones so that we don't get any feedback?
That's only one. The one that that needed to be addressed.
And so, Chris, the other pieces were what we talked about, and I'll just kind of run through the big items real quick because I know we're pressed for time. One thing that the self-advocacy group identified was that the exceptional services should be available for more than just clinical, residential, or day training sites. Also, case management doesn't have a component for exceptional funding, which most states do have built into their waivers. You're pigeonholed into getting only exceptional supports in certain caveats. So you can have residential exceptional supports, but you can't have day training exceptional supports. There's no avenue for case management to do exceptional supports with a client that requires more intensive services. The technology model in Kentucky, that's not even applicable to exceptional supports, which already prohibits people from being able to access that support. And so for people to be healthy and successful, we have to look at not just limiting the exceptional support process to certain services. There should be an examination of what services qualify for it. It should be expanded upon, and people should be able to have more robust options when it comes to that. Now, also, the exceptional supports, as we said, across multiple services. Right now in Kentucky, if you can't have residential and day training exceptional supports, which the participants have voiced a concern about, because if people are getting residential services and they're approved for exceptional supports, then you cannot make a request for day training exceptional supports. The only avenue that works currently through is if the residential provider is approved, they have to contract out a rate with the day training provider, which makes it very convoluted and very messy, and it's hindering people from accessing the full array of services. And similar to that, you have some participants that are living on their own, who may either be in their own apartment or self-directing services. And personal assistance is a service that if people are wanting to live on their own, there's no mechanism for them to get enhanced funding if they require additional medical needs like Shauna. Like Shauna is going to have an extremely difficult time moving out of a traditional residential model to something else, because she would have to fit in this box of services that isn't really defined to meet her needs. And so the exceptional supports, from my understanding, was meant to be applicable to folks that don't fit into your standard model of service. And so people that participant direct may need 2 staff at one time, or people living in their home that may need two-person transfers, that doesn't exist. The other piece to it, which many families and participants alike have also discussed, is that crisis services in Kentucky are insufficient. Not all crisis services are done equally. Life Skills does an excellent job. Centerstone does an excellent job. But there's a lot of people that experience immediate crisis that the current crisis response units aren't equipped to handle. And so the exceptional support should be something that participants, families, and providers know is there as a resource. There shouldn't be any confusion in what a person can qualify for and how long the funding will be in place. Many states have long-term funding in place for people and funding readily accessible for emergency interventions underneath that kind of scope. And so, having those things in the community and having providers really be able to access them, and families and providers as well, and participants, we can look at people going into Eastern State Hospital or Oakwood and then being maintained in the community, which was the initial scope of the crisis response unit. And so those were the major issues that the self-advocates had identified. And so I'll turn it back over to them for questions, or if I can help out anymore.
Yeah, thank you, Brandon. I think we do have a couple of questions. One of the things that I want to follow up with before I go to my list for questions is, you talked about, how we have to do a better job of accessing the available services. Let me ask you a question about if it's an access to available services, do we actually have the providers in Kentucky that will do those services? Do we have any type of provider issue relative to that access issue?
No, it's more of a definition of the exceptional support itself.
Okay.
Certain services are defined to be able to, you can apply for exceptional supports for certain services. It's predefined. But there should be additional services that you could examine exceptional supports for, like the personal assistance piece that we were talking about.
Okay.
So you have to separate out the residential component and then people that live in their own home or a family home. So people that live in their own home or a family home access personal assistance services as opposed to traditional residential. So right now, there's not really a good avenue for getting additional supports in someone's own home or family home through the personal assistance service. It's not that there's no providers providing the support. It's just that you still have waiver limitation or regulatory limitations
Limitations,
on how the
yeah.
service can be provided.
Okay, that's a good answer. Let me go ahead. Senator Parrott has a question for, I don't know which of the four he has a question for, but I guess he can, if he's ready to go, please, Senator Parrott.
Thank you. My question is for Chris DeBrandon, and it goes back to the start of the meeting. The question that I had, what are your ideas of how to handle the transportation part when you need it in rural areas? That's a tough thing, that rural area, and then trying to fit all that transportation. What is your suggestion to fix that?
Oh, Chris, you mean?
Maybe,
Chris, go ahead. Chris, check your mute button.
can you hear me now?
Yep, we got you now.
Okay, maybe accessing Uber in some way or different taxi companies. Cause right now in rural areas, there's no opportunity for people to go in the community to get a job. That's why I brought up that. Transportation is very limited.
Sure.
And Chris, just to build on that, like, this is something that University of Kentucky Human Development Institute was working on. And they had reached out to the provider groups, they had reached out to self-advocates, and the rural piece is, even in Lexington, transportation services struggle. If you go down to Eastern Kentucky, really an avenue that would be open to folks is that there's providers of service for Medicaid long-term care waivers throughout Kentucky. And they can go through the process of being a subcontractor for a broker, a transportation broker. However, that process is so convoluted and extreme that a lot of providers don't do it. You have an existing framework of Medicaid-based providers throughout Kentucky that could potentially, and have the resources in wheelchair accessible vans, all those things, to be able to pick up some of the slack in rural areas. However, they really, for lack of a better word, it's just complicated. It's too difficult for providers to maneuver through that system.
Do we have any more questions? Representative Riley?
Yes, the last gentleman spoke. The question I'd like to ask is, how can we make this less complicated as far as providing transportation for those folks, especially in the rural areas that you're talking about? For a little while after I retired from my previous career, I drove for one of those transportation companies and drove elderly and disabled to doctor's appointments and such, and I know those exist. How do we make that process less complicated?
Well, right now, we had talked with, the transportation cabinet about this way back when. And we had talked about, like, if you sign on to do it, and I think this is still the way it's handled. So transportation brokers get X amount of dollars, and the less transportation they provide, the more revenues they get, the more profit they have. So that already is a system that already kind of, I don't want to say rewards them, but it's more positive if they subcontract with the least amount of vendors that they can. And so that's counterintuitive to what we want to accomplish. The second thing is that you have to go in and apply, and there's several months of red tape that you have to slash through. Anyone else who is providing transportation in certain counties can automatically deny your ability to provide transportation services. So like in Lexington, if you want to apply to be a subcontractor or a broker, with the broker, people can, like a taxi cab company, can automatically object to your being a vendor. I don't know if that's still the case, but I know it was a few years back. But the funding mechanism by which the transportation, the non-emergency medical transportation works is the biggest hindrance, coupled with the red tape that a provider would have to go through in order to provide it. But you've got, like I said, you've got the existing network there. It's just heavily underutilized.
Okay, it looks like, thank you very much for your all's presentation, and it was very good. We don't have any more questions yet, but I really thank you and anticipate us reaching out and following up with you on some of these issues that you brought up. Next up is Steve Shannon, who's the Executive Director of the Kentucky Association of Regional Programs, and he's going to talk to us about an analysis of exceptional support waiver services from the perspective of regional providers. And Mr. Shannon is with us at the table today, and he will be presenting from the committee room. Please proceed.
All right. Thank you. Appreciate the opportunity. It's kind of an exciting time to talk about this issue. First, I'm going to do my shameless plug for mental health centers. There's Cards Association 11, there's 14. We employ about 8,000 people, serve 180,000 people annually, about 1 in 25 Kentuckians. And significantly, we're led by 300 volunteer board members to chart the course. I say community mental health centers make communities better through exceptional services, good jobs, and extraordinary volunteer leadership. The other piece about mental health centers, we've been involved in the SEL program and its predecessor, the AISMR program, since it started. So we go way back on this. I was an SEL provider when I worked for a living. Now at the association, I talk about stuff. We've been talking about this issue going back to 1991. I have a memo that we submitted in 1991 of the need for an exceptional support mechanism, high intensity. I attended meetings in 99 on this issue. I got notes of those meetings. We submitted a proposal in 2003 in collaboration with Bluegrass, now New Vista, Children's View Program, using a tool to come up with a plan. To 2017, there's the exceptional protocol we're under now. So we've been active in this issue for 31 years. I personally have been active in this issue for 23 years. More significantly, individuals and their families have been active in this issue for a lifetime. We need to figure out how to make this work for them, not for me. Not for my members, but for the individual served. Can't turn paper with a mask on. Sorry about that. One thing we did, I talked about this, we did a survey of 300 plus SEL providers, SEL recipients, individuals, in the early 2000s using the tool, the ICAP, and came up with a tiered reimbursement methodology and submitted that. We have that information. So there's work that's been done to figure out how to make this work for individuals, not just for providers or the payer, how to make it work for individuals. That's the most important thing. The author of that tool came to Kentucky at our invitation about 2000. There was a long-term living initiative summit in 2006 to discuss this issue. We've talked a lot about this. It's time to move forward and do the right thing. The current protocol we have, dated March 1, 2007, clearly says exceptional supports are for the sole purpose of ensuring the health, safety, and welfare of the waiver recipient. We endorse that 100%. We think that has to be the focus. That's going to generate the outcomes we need to have accomplished. If the current system worked, why would we be here today? Clearly, there's concerns. There's some positives. There's two great things about it. One, it's based on the individual for the residential supports or day programs, as Mr. Griffin's referenced. It's not all services, but it's driven off the team and the individual. It's not driven off the regulations or services. They participate, they help develop the plan, they get supports. They should have confidence in that plan. It's going to meet their needs in the community. That's a good way to approach. That's a good start. The second piece is the providers of those services can feel confident those services are going to be viable, that they can provide the services to generate quality outcomes for people, tangible outcomes, changes in their lives, but not go broke in the process. That has to be a real concern. One example, one agency, one mental health center, lost $100,000 a year for 3 or 4 years on one person because the plan wasn't approved. You can't lose $100,000 a year on one person. Maybe you can once or twice. You can't do it for 2 people in a year. It's just not viable. It has to work for people. When I approached the people that direct services at the mental health centers, 11 members, I heard things like, I heard the recoupment issue. They come back and look at what you spent. Maybe you had a plan to pay someone more money and they worked overtime, had to pay overtime. That wasn't part of the plan. That may have been recouped. Other dollars were recouped. Great fear of having those dollars recouped. Heard things like it's a lengthy process. A lot of documentation is needed. The time isn't worth the investment. It's not worth it. So people are reluctant to go through the process. It's not a fluid process. We acknowledge the plan needs to have checks and balances. We acknowledge it just can't be, here you go, a pot of money, do whatever you're going to do. We buy checks and balances. We accept that. We have concerns, though, that do those checks and balances to make sure plans are approved, people get the services, is that a deterrent to other people applying through their case managers? I think you heard from Chris and Shauna. They have concerns about accessing services. I think Brandon referenced it. Are there people not making application because that process is too onerous? Are they saying, we don't think it's going to be approved, we want to go through the exercise and accomplish that? That's a real concern. Folks who need exceptional supports need to get it. Shouldn't be dependent on the ability to submit adequate documentation and invest the energy. Kind of like managed care prior authorizations. If you're reluctant to get it approved, you're probably not going to submit it. Do something else. That's a concern, or people not accessing services. So the first opportunity of 4 I see before us, let's make the process less onerous. Sure, accountability and tangible outcomes. Focus on the individual, but make it less onerous so it works for the provider. The second thing is the approval process. A lot of folks I talk to, I came to CARP in 1997. 2 or 3 people I spoke with were already part of the group before I got there. They've been doing this for a long time. Let's make the approval process. Now it appears to be it's a yes or no. Submit a plan, it gets approved or not. There's no dialogue. There's no discussion. Why do you recommend this? Have you thought of this? Perhaps before the plan is up or down or for approval, there's a conversation. I think that conversation will generate better outcomes for the individual. You may get a plan that the state feels good about, has accountability, providers can do, but it meets the individual's needs, as opposed to just a yes or no. Because what happens now is, if there's a no, you start the whole process over. And what happens to the individual while you're waiting through that process? So again, the first one, make it less onerous, maintain accountability. Second one, let's have a dialogue about the approval process to see what can happen. The third item we talked about is the length of time. And you heard this from the previous group, and they were correct on this issue. They nailed it pretty well. Certain services are going to last a long time. If you need a catheter, that's not going to change every 6 months. Make it last longer. If you need additional medical support, that may not change every 6 months. Don't make the plan last for 6 months. So we think the plan should at least last a year. A lot of work goes in, you figure it out, you get it approved. It's going to take some time to implement it correctly, and it goes on. So the 6 months process, you start over. The fear is you get approved for 6 months, maybe you're doing a little bit better, you don't get approved again. You kind of churn in and out of that exceptional support. You get it, you do a little bit better, you might lose it, you get it again 6 months. So every other rotation, you may get it again and lose it for a while. That's not beneficial. It doesn't accomplish the objective of focus on the individual's health, safety, and welfare. So how can we do that? So I think the third thing is go to a 6-month plan and a pretty easy, maybe not easy is the right word, but a methodology for a 6-month renewal beyond that, that is much more, meets the needs of the system, but doesn't require a huge amount of documentation and support and effort to get it done. So you go to 18 months, and you feel good about 18 months. I go back to Shauna. If Shauna needs an LPN today, she may need one for a long time. Why do we have to submit the paperwork to get it again? But the third option we talked about was go beyond. Go beyond the 6 months, a year initially, and then maybe an expedited review process for the next 6 months. You get 18 months worth of services and then see where you're at. Folks who get exceptional supports have pretty significant challenges in their lives. They want to live in the community. We want to make sure the system allows them to do that and not have this clock running that we're all panicked about. So again, the third action, 12 months, expedited review, maybe another 6 months. Get 18 months worth of services. I think that's fair. Fourth one, I think we need to pick an assessment tool. There's tools out there, commercially available tools, that we can use, become very adept at, be successful with, that gives you an idea of what's taking place. As I said early on, in 2000 or so, Brad Hill, who was one of the authors of the Inventory for Client and Agency Planning of the ICAP, came to Kentucky, spoke to consumers, families, providers. You know, the whole world was invited to participate in that. That's one tool, the ICAP, still available. I was in a meeting with Medicaid staff a couple of years ago, talking about the ICAP for a different waiver than the Shell P waiver. It's still out there. The American Association of Intellectual Development Disabilities has the SIS, Support Intentionally Scale. It's a good tool. That's one. At one time, Kentucky used what was the NC SNAP, North Carolina Support Needs Assessment Profile. Now, if you're not in North Carolina, it's the DD SNAP. That's a good tool. It's still out there. We used that tool for a while and added on a one-page healthcare one. Everyone gets a health risk screening tool now. So there's tools that are available. I think tools, a standardized tool that's reliable and valid, helps you direct where the services ought to be, and you end up with a recommendation that meets the person's needs. Okay? I think you have a tool. It may address the onerous process, and it may address the time process. Because one, you can see what changes year to year based on that tool and how it's used. So I think we need to select a tool. So in conclusion, again, the 4 areas is make it less onerous, so there's not a deterrent. We don't want the checks and balances to be a deterrent to make an application, because that doesn't benefit the individual. Second is, I just lost, where's my second? There it is. A dialogue for denials primarily. We think this needs to change, and then you're focused on the individual, not the ability of the provider. And I'm a provider guy, I represent providers who submitted the documentation. You want the decision to be based on a conversation with the individual and the team, not on what I submitted as a provider. Third, go to a 12-month process for approval. So the plans typically run a year. You go to 12 months for the exceptional supports, and then you add on the 6 months again, kind of an expedited renewal for that period. You look at where you're at in 18 months, and I think you pick a tool. I think we need to have a standardized system to make it work. Those are the 4 things that came out of the conversation I had with folks. We then talked about the work of the task force, and I admire you for doing this. This is, again, 29 years we've been at this conversation, and we made progress in certain areas. But there's certain things I think that help us with our deliberation going forward. I have 4 of those. One, you got to remain focused on the person. You got to remain focused on that individual. Force intensity scale clearly states we're focused on the health, safety, and welfare. CMS, our federal partner, clearly states the waivers are to gain and maintain skills for community engagement, employment, and relationship building. Focus on that issue. Go from there. The process needs to be budget neutral. Waiver rule world, there's a thing, budget neutrality, and that's you spend as much in the community as the facility, but that's not what this is. This is we can't come up with a system and not adequately fund it. Because if you just come up with recommendations, you will have winners and losers. The problem we faced in 2003, where we came up with a tiered reimbursement model, is we couldn't spend more money than the universe of SCL at the time. And therefore, some services got a lower rate. Not a good plan, because as you legislators on the panel know, you don't get calls from winners. You know, you get calls from the losers. And there is, you know, there'll be a migration away from some services and some people. We don't want that to happen. So you got to acknowledge going in, if that's a guiding, if we got to get away from the budget neutrality, the budget neutral perspective of the waiver to make sure there's adequately funded for exceptional supports. So people can do this, the system can do this, and you're not penalized. You're not telling our Medicaid partners, here you go, Commissioner Lee, spend the same amount of money, but do more with the same amount. That's not viable. Hasn't worked. I also think you have a conversation about the populations that need an exceptional support. I think those are real things we need to at least think about. I think you heard some from Shauna, the issue around medically frail. I have healthcare needs that exceed what most people have. That's a real issue. I also think you got to talk about aging in place. A lot of people in the SCL program have been there for a long time. I know, my own experience with aging, it costs more money than you did when you were younger. You know, My parents required more support, my mother-in-law required more support. You know, my kids will tell you I require more support. It's gonna cost more money. We can't ignore that piece. We gotta at least talk about that, have that conversation. You got folks with challenging behaviors in the SCO program. That's one of the big targets of exceptional support. So we gotta at least acknowledge that. It was touched upon by Brandon that there are some people who get exceptional support and are using those state general fund crisis dollars. If Medicaid can pay for part of it, it'd be better off if Medicaid, you spend 30 cents, 28 cents, whatever the match rate is now versus $1. There are people, but what is that piece? We also have a lot of folks who are involved with the criminal justice system. I had a conversation a couple of years ago with the chief of police of a town in Kentucky who knew the person specifically, who calls every day. And the message that he said, we need a secure unit that person can go and stay for a long time. Don't think that's the answer, but it's a conversation, criminal justice involvement. And folks with co-occurring mental illness, we need to talk about those people. Those last three may have some overlap, but it's just not going to be one fix for everybody. Nursing's a real thing. We need to acknowledge that. In-home supports may change as you get older. We need to acknowledge that. And challenging behaviors is a thing we got to at least talk about. Also, put my provider hat back on. There can't be an expectation that a provider supports someone in the community and not believe, as a provider, there'll be sufficient resources to do that going forward. You just can't operate very long with that premise that if I used to be back in the glory days, as I was told, you make enough money off client 1 through 9, you can lose someone 10. 1 through 9 is a challenge now. So if 10's more expensive, there needs to be enough money to support number 10 in that process. You can't expect providers to do it for nothing. In conclusion, we've been talking about this for a long time. I think this is an opportunity to have a real conversation and come up with recommendations that, again, focus on the individual, allows the Commonwealth to feel good, accountability, their federal partners to feel good that it's an accountable system, and providers can do the work they want to do and not be at risk of losing money. That's the CMHC story. Any questions?
Steve, thank you. It's, you're just such a wealth of information on all of this.
That's a polite way to say I've been here too long.
You've been there not long enough. You can never go away. But you know, it's just thinking about kind of generally what your statement was. We've been working on this since 1991. I mean, it's because I think this is such a dynamic space in which to work. And so it's hard to put guardrails up on a dynamic situation. But at the same time, you need to put guardrails up, but you also have to have that flexibility. And that flexibility is so key because each person is an individual and they each have their individual challenges. And so, you know, those are really challenging parameters in which to work. I guess one of the things that I want to ask you about is, you know, the Bevan administration spent a whole lot of money on this Navigant study and trying to determine who was in what waiver, should they even be in that waiver, what were the services available within that waiver, because we were operating in these silos.
Correct.
And to be honest, I don't even know whatever came from that contract. But I guess my question to you is, were they on the right track as far as allowing for this flexibility? Are we going to a only one waiver and then we'll figure out all these different a la carte items? I mean, I guess what is it that we're kind of generally looking for in order to serve the individual?
Yeah. And I wish I had that answer.
Yeah.
It's a great, but I think this is an opportunity to have that conversation. The Navigant report was robust, covered a lot of stuff. It did initially look at consistent language across waivers. Sounds kind of silly, but that really makes a difference. So the service is called the same thing. Try to get rates consistent across the waiver. So, you know, there's really 6 waivers.
Yeah.
There's a Model 2 waiver, which was ventilator dependent. That wasn't part of Navigant. But there's two brain injury waiver, there's a home and community-based waiver, there's a Michelle P. waiver, and the SCL waiver. I think this group is the SCL waiver.
Yeah.
But they kind of make consistent language across those five. Try to get consistent rates for services across those five. Because if the service definition is comparable, the premise was the rate ought to be comparable. So that was a good conversation to start, to go down that road. I think it's a really big lift to get all waivers in a line that quickly. I think what happened also with Navigant, again, it goes back to being budget neutral. Their assignment was, you can do whatever you think is best for the waivers, but you can't spend more money than we're spending currently. And in that model, I remember correctly, the brain injury waivers kind
And
of.
is that because CMS says that or the state
I think
says
that
that?
was a state, CMS has this budget neutrality rule. that
Okay.
You can't spend more, person in the facility can't, the community can't spend more than an ICF or an institution or a nursing home. So that's their big picture.
Okay,
But this was budget neutral. You know, it's kind of like if you got a piece of pizza with 8 slices, you can do what you want to your pizza, but the bottom line, you still have a large pizza. We're not
okay,
getting an extra large pizza. It's going to be the same size. But I think that was part of the challenge that was done over that process. Prior to that, Deloitte was looking at the waivers as well, and what can we do at that point? I think the real challenge is, how do you get to the system? And your guardrails is a very apt analogy. I would hope those guardrails were made of rubber, not steel.
yeah,
I think what's happened now, we're kind of steel guardrails, and you get it, and you get it for 6 months, and you hope you get it. How do we get to a place that it really meets the person's needs and just meets their needs? I mean, we all want a lot more stuff, but maybe if you focus on needs, you can accomplish that and see what it looks like. You know, if it's a residential rate, that's the big expensive piece. So there's a lot of conversations about residential day program, but I think you got to look at what people really need. I think you got to add nursing to it, and that can't be done for free. I mean, there's a lot of folks, home of the innocents, we've heard them testify.
yeah,
People age out of home of the innocents. You know, I sat in the back row and heard about that, and we're kind of surprised that after age 22, there's age 23. I mean, I knew that a long time ago. Where does the person go when they age out of home of the innocents, right? Do we want them to go to a nursing home? You know, I got a 23-year-old daughter. I don't think she wants to live with a bunch of old people. I mean, she's not going to do that. You know, so I think we got to figure that out. So I think that's a different population. But I think this is a place to start the conversation. And what can we do to make it viable and work for the individual? Because it really worked for the individual. And the provider believes they're confident they can do it. I think we can get a system that meets those needs. I still go back to a tool.
Do you think that this is that piece about how do you serve that individual, is that a case management component that we could do better, or is it a cabinet thing that we could do better? Like, what is
It's
it?
the planning process that the team has, and that's one of the assets that we have today, and figure that out. But I think at some point, we talked in 2003 about using a tool to come up with tiers. So maybe you're a level 5. And in 2003, level 5, our proposal, believe it or not, and that was $2,003, right? That was a long time ago. Actually, it was level 6. If the basic package was $36,000, staff resident was 85, it's more than that now, but that was a level 6. And within that, you had the flexibility to figure out how to make it work. So it wasn't dead on to the person, it wasn't their specific situation, but can you get them into a tiered model and look at that? That's a way to start in the process, and you go from there. I think at some point, a conversation between the Michelle P. and the SCL waiver. What's the interface between those? I think Michelle P. didn't exist when we did this, but I could see it was a level 1, you got no support. You know, you scored, you're okay. 2 and 3, residential, even a staff residence, or other residents, you got $42,000 for a staff resident, or 15 for like in a home with somebody else. Maybe that, the residential piece makes you SCL, the general fund makes you Michelle P., or the other services, not residential or Michelle P. But I think you got to move in that direction.
Okay.
You know, I like the individual model, but I don't want to think people aren't getting it. That's the only concern.
Yeah.
But if you get a tier, maybe you can say, okay, this is what you're eligible for. Let's talk about how we're going to spend that money.
Okay.
Kind of a PDS model. But
Yeah.
how can you do that and make sure that it works for people's needs? And they don't live in a staff resident, they don't live in a supervised 24/7 home, they don't get as much money for that. I think that's fair. So I think you
Okay.
got to start looking at how to use that tool, get to a place that it makes sense for people. And capture health needs, because that's a real issue that we haven't done a great job capturing.
Yeah, okay, thank you. And we have Representative Bojanowski has the next question.
Okay, thank you. So this is a kind of a broad question, just getting into understanding this. Why do we need this exceptional support waiver in the first place? I mean, is it because SEL is statutorily not allowed to do certain things, or is it a
No.
budget issue?
It's the existing parameters for the SEL service is in regulation,
Okay,
okay? So you got to fit, and the rate's in regulation, okay? I think the residential rate's 173 a day, you know, offhand, whatever the number is. That's what you get. That doesn't support everybody, okay? So the exceptional support is really not a waiver. It's a piece of the SCL waiver that some folks make application to and get additional funding to support that person.
okay,
And that's why, and it was done because, you know, one size fits all is really one size fits none. And that's kind of where the SCL was at this point. So you had someone who required one-on-one staffing. Wasn't a way to do that. But maybe that happened before. Folks said, we can't do that forever. Let's figure out some other way. And the exceptional support was that. It was an add-on to the SCL program that, again, we started doing this with the NC SNAP early 2000s. That was a result of the 144 Commission, which is the Kentucky Commission on Supports and Services for People with Intellectual Development Disabilities. Had that conversation. Then we went to this protocol in 2017 as part of the SCL waiver, not a standalone distinct waiver.
thank you.
Do I have any more questions from any other members? All right, seeing none, thank you very much.
Thank you all.
I've got a comment for Steve, if I may.
Yes, please proceed, Senator Parrott.
Thank you. Steve, first off, I want to thank you for your many, many years that you've been serving this area for a long, long time. You've done it very professionally, and you're committed to it, and you've done a lot. And I just want to make that public that you've been a gentleman, and the things you've done have been amazing. But I want to touch on the waivers a little bit. So listening to you, seemed like you focused on making it less onerous, making sure there was good dialogue with all the parties, and then I think you mentioned a 12-month process, which
Correct.
it is, and then the budget neutrality. Those four things seem to be what your focus was. Is that correct?
And I think we need an assessment tool.
So, okay, gotcha.
Yeah.
Okay.
And again, it could be the ICAP, this DD SNAP, you know, those are all buzzwords within the field, or the,
Okay.
you know, whatever the assist, support boards. We just need a tool that we all feel good about, and that provides predictability as well.
All done? Okay, thank you very much.
Thank you.
Next up, we have Amy Stade. She's going to
And I
talk to
do
us
have a
about perspective of private providers. Amy, are you up?
I'm here, can you hear me?
Yes, we can hear you. We just can't see you, but we
Okay,
can hear you.
I do have a PowerPoint, so hopefully you can see that. I don't know what your view is, but I'll kind of run through this.
Yes,
you
it's
guys-
up.
Okay, perfect. So just quickly, my name is Amy Stade. I am the Executive Director of the Kentucky Association of Private Providers. I just wanted to thank you all for allowing me to present today and for allowing me to be a member of the task force. I really appreciate it. I really appreciate the opportunity to talk about this incredibly important topic that, as Steve so eloquently pointed out, we've been talking about for a very long time and still haven't quite worked through. CAP, as we call it, is a trade association representing 1915C waiver providers. Our advocacy primarily covers the supports for community living and the Michelle P. waivers, but our members do provide services and other waivers. We've got about 105 business members that are individual businesses, My members employ about 9,000 Kentuckians and support around 10,000 individuals. So, we're a big network of people. If you want to go to the next slide. So when I found out about the Exceptional Supports Task Force, I kind of quickly surveyed my members and really asked two fundamental questions about exceptional support services. One, I asked them, does the current exceptional support system provide SCL participants, the individuals with disabilities that are being served, with the support they need? The overwhelming response was no, it does not. The individuals served that need exceptional support still don't get the supports they need. The second question was, does the current exceptional support system adequately support providers to provide care to individuals with significant care needs? The overwhelming response was no, it does not support providers who care for individuals with significant care needs. Next slide, please. So I'm glad I included this. I was a little afraid since I went last, but as Representative Bojanowski sort of was asking about, I kind of wanted to quickly run through what an exceptional support service is. So this is literally the definition from the payment reg. It's 907 KAR 12020. So in the definition section, an exceptional support is a service that is requested by the participant and the participant's team. It's due to an extraordinary circumstance related to health, safety, and welfare, psychiatric issue, but it's a service that's provided in excess of the upper payment limit for the service, and it's got to meet the assessed needs of the participant. Next slide. So, as outlined in provider letter A49, which is kind of the real outline of the exceptional support system, was issued in 2013. Exceptional supports are just to ensure the health, safety, and welfare of participants. They're based on the needs of the participant, meaning that the team's coming together and talking about the individual and what they need and what kind of services they need in order to thrive. They're supposed to be for a limited amount of time, not to exceed 1 year, but as we've heard from others, these exceptional supports are typically approved for 6 months, and they're generally provided in excess of the upper payment limit or the unit limit, meaning that they're the established reimbursement rates or units that you can bill. Exceptional supports are services that you can bill more for or provide more units for. Next slide, please. So this is just quickly services that are eligible. The first group are SCL services that are eligible for higher reimbursement. So community access, day training, personal assistance, respite, residential 1, residential 2. Typically, we are seeing that these services are being utilized by residential agencies to provide one-on-one supervision. And I put that note in there that if a residential service receives exceptional supports, rate increases aren't allowed for any of those other services. So if you're getting it for residential to provide one-on-one care, none of those other services would be eligible to receive enhanced rates under the exceptional support system. Also, as you see below, certain services can use the exceptional supports process to ask for increased units. So while they are being reimbursed the same rate, they can ask for more units be provided. And those are consultative clinical and therapeutic services, coaching, personal assistance, and respite. Next slide, please. So this is really important too. Which individuals are receiving exceptional support? So generally, if an individual is in a crisis situation, they would, be eligible to receive exceptional support. There are emergency provisions where you can get them pretty quickly. Two, and we're seeing a lot of this, are individuals who require a high-level support. This is an individual who generally might have a co-occurring mental health condition. They're receiving one-on-one supports in a residential setting. These are individuals with really intense support needs. And this third category of individual, these are people who actually individuals, there were no unit caps on services like behavior support, psychological services. When we transitioned to SDL2, we combined behavior services, psychological services, and nutrition services into a service called CCT. It's Clinical Consulting and Therapeutic Services. And we put and I'll talk a little bit about this later, but we put a pretty low unit cap on that. And a lot of people lost access to the services that they received under SDL1. So these are individuals who are just, they don't have exceptional care needs. They just need a few more units every month of the services that they previously could access. Next slide. So after consultation with my members, we kind of identified several problems. So the first of which is the way that the current regulations are written, providers are deterred from agreeing to support an individual with intense support needs. So what does that mean? Right now, the way the referral system works in the SDL waiver is if you are a provider, you send out a referral, and you accept that referral, that individual, you'll do an overnight visit, that individual will come to live with you. If 6 months down the road, you realize that this individual has very intense support needs that your agency just is not equipped to support, you can institute a 30-day notice of involuntary termination. So then you send out referrals to other providers. The unfortunate thing about the system is that if another provider does not accept that referral, you have to continue to serve that individual until someone will accept that referral. And as we've kind of noticed in the SDL system, once an individual who has maybe extreme behaviors or is incredibly violent is identified and kind of pegged as someone who's very hard to serve or someone who's violent, no one will accept that referral. And so then a provider who has admitted that they are not equipped to care for this person, that the staff isn't safe, that the individual is not safe in this instance, has no mechanism to, there's no mechanism for this individual to be, to go somewhere else to live. And this provider has to continue to support someone who they have admitted that they cannot support, that they don't have the resources to support. And that's a huge problem. The second, as others have noted, is that there are potential recoupments that deter providers from agreeing to support these individuals. One provider said to me, in fact, that it becomes more about the documentation than it does about the client. And the documentation for these services is intense, and especially when you get into the budgetary components of it. Unfortunately, the way the system's designed now, it leaves no mechanism for any provider to, calculate in overtime or any of those costs, and it really can come back and end up in recoupments for providers when they put on their info sheet that they're going to pay someone $15 an hour, but then that employee's in overtime status, so they reduce, the pay, so they don't end up paying that person $30 an hour. A very complicated and convoluted process that gives people a lot of fear that, every dime that they were reimbursed is going to be taken back not due to the fact that they haven't provided quality services, but due to a documentation error that does not relate at all to the quality of care the individual receives. While we certainly understand that this is a documentation-based business, we can't justify our services if we don't document them. But people should not live in fear that, minor documentation errors are going to result in a complete recoupment of of all the reimbursement you received and have likely reinvested in your business. The third thing is, again, as others have noted, is that the exceptional support application process is really overly complicated. It requires a ton of documentation. The time frame, there's a 24-hour turnaround kind of on when you decide to apply for it and when you have to submit the documentation. And then we have this whole system called LOIs. And these are lack of information requests. So a provider will, the case manager will submit all of the documentation, the whole big packet, and then these Medicaid or DDS Medicaid will send in these LOIs saying, can you clarify this? Or can you clear this up? Or your salary calculations aren't quite right. That kind of delay the whole process. Meanwhile, a provider may be providing exceptional supports already. And the thing about this is that these LOIs delay the start date, and there's no mechanism to backdate the start date of the exceptional supports to when the team, originally submitted the documentation. So these LOIs can really slow down the process and created a lot of issues for providers. Something else that I think Brandon may have alluded to is the long-term supports after stabilization. So SDL providers have called it, they're victims of their own success. So what happens is someone will apply for and receive exceptional support. So let's say this individual, lives in a residential setting, gets one-on-one staffing in a residential setting, and gets, intense behavior support services, and that person is now stable. But that person also comes to rely upon these services. So after once you stabilize someone, you start to get pretty intense pressure from the cabinet to step down those services and lessen the support. And then people can destabilize really quickly. And then you have to go through the whole process again, reapply, ask for more units of exceptional support. Someone described it as you need a skilled grant writer to make the case that a participant will regress if the exceptional supports are removed. And that's so true. It takes a lot of time to just continue the services on administrative burden to just justify continuing the services that are keeping people stable and the services that people need. And it's a big problem for providers. As I mentioned earlier, with the consultative clinical and therapeutic services, under SDL1, there were no caps on these services. We certainly wouldn't advocate going back that way. I think that there was probably a lot of not prudent using of state resources during that time. But right now, those units, so again, it's a bundled service. So you have to split the units allocated every year between behavior support, psychological services, and nutrition services. It is capped at 160 units a year. These units are 15-minute units. And so that ends up being 40 hours a year, not per service, but in total between these three services. That's 3 hours a month. And so people went from no cap to a 3-hour cap a month that they have to share that 3 hours with nutrition, behavior support, and psychological services. And that just is not cutting it. And these people have to, the case managers and the individuals who need these services have to go through this burdensome and confusing and time-consuming exceptional support process just to access increased units and services that they had access to in 2013. And so that is
Amy, who put that?
Yeah.
Amy, who put that cap on? Was it CMS or was it state? How do we?
It was the state through regulation. So when they implemented SDL2 in 2013, they made that transition.
Okay.
It was outlined in the new SDL regulation.
All right. Thank you.
You're welcome. Next slide, please. So the exceptional support rates, there are several rate calculations, but I just included the one for residential because it wouldn't fit in the slide. They wouldn't hold it in the slide. The rates are calculated using this arbitrary formula. So this formula is not based on anything mathematical. It is the result of a negotiation between the Cabinet for Health and Family Services and providers. And essentially what the regulation says is that you cannot, the exceptional rate reimbursement, the exceptional supports reimbursement cannot exceed 2 times the upper payment limit, which is the rate. So for residential 1 services, the upper payment limit, the reimbursement rate is around $189 a day. Just to contrast that, the per diem for an ICF, which is, the institutional kind of care equivalent or other option um, to community-based care, that per diem is $1,200 a day. It's a little more, but I rounded down. It's $1,200 a day. So, your community-based care is an 85% cost savings right off the bat. So your exceptional support rate for residential, 2 times a max of 2 times the regular rate. So the most your exceptional support residential rate could be is $379 a day. That's a 70% cost savings from an ICF level of care. So we've got a lot of wiggle room in there with cost neutrality. Again, CMS requires that any of our community-based programs cost less than ICF level care. So we've got a lot of play in there to work with to meet those requirements. But if you look at this calculation, it's impossible to figure out. And providers report that they try to figure it out, and then Medicaid often will come back and say, no, you calculated this wrong. Here's the calculation. And then Medicaid just has to figure it out, and the providers just have to trust that it's right. And so I really thought it was important for the group to see this actual formula and see how it is the result of a negotiation and not based on any sort of cost data provided by providers. Next slide, please. So when you apply for exceptional support, part of the regulation states that exceptional supports need to be based on cost data. This right here, what you see on the slide in front of you, is the only cost data they ask you for. It's hourly pay. I think we all know that a lot more costs go into providing care and running a business than hourly pay. This makes this doesn't allow providers to work in the cost of overtime, which is a massive issue in this population right now. SDL providers are struggling. There's a huge workforce crisis. They cannot hire anyone because they don't have the money to pay staff $15 an hour, which is pretty much the going rate right now. SDL providers don't make enough to pay staff that, and it's incredibly difficult to find qualified staff to serve these sometimes, hard to serve populations, especially when we're talking about individuals with exceptional supports in residential settings. Again, some individuals have some anger and aggression issues. Not all, we're talking about a very small portion of this SDL population, but it's the most difficult to serve. Next slide, please. So here's the cost breakdown. This is one SDL provider, and if you kind of scroll to the bottom, this is one-on-one residential support. To note, this is 7 individuals that this one provider serves. They lose $400,000 a year on 7 people. Essentially, they're basically paying the state $400,000 a year to support 7 people. Can you scroll to the top, please, again? So they are reimbursed for these 7 people in total, $798,000 a year. And this company spends $1.2 million to support these 7 people. And this is just not, this company cannot refer out these individuals. They're clearly bleeding money. They've stated they often, and can't support them. And they have no one will take the referral. So here they are just kind of stuck losing $400,000 a year. And these are businesses that operate on really paper thin margins. And we can't expect our provider partners to provide care at such a significant loss and without giving them any options. It's tough. And this is just an overview of all of the different costs, I wanted to contrast it again against that previous slide that showed just the wages. I mean, this is really the costs that go into providing care. We've got overtime, base pay, you've got maintenance for the residences, sick wages, insurance, business insurance, benefits, all of these things go into providing care, but the current cost calculation really only allows you to include wages. and not even overtime wages at that. Next slide, please. So I'll just run through our recommendations really quickly because I know we're running out of time. So one, overwhelmingly, CAB members believe that we need to establish a higher level of care while also retaining our exceptional support system. So what we would do under this scenario, we'd establish a higher level of care for individuals whose support needs are just greater than what can be provided in residential level 1 and residential level 2. This would not be ICF level of care. It would be in the middle of those two. In this scenario, the exceptional supports would be used exclusively for short-term crisis mitigation and crisis stabilization. Next slide, please. We also need to do a little work kind of overhauling the current system. We need to streamline the application process. We need to overhaul the rate methodology just to ensure that it's truly cost-based. We need to simplify the exceptional support billing procedures. They're pretty complex, and it leads to a lot of frustration from providers. We need to overhaul the SPL referral system to ensure providers are not deterred from accepting a high-intensity referral. We need to increase the consultative, clinical, and therapeutic service unit limits so that participants have access to the services they had access to under SPL 1. And we need to establish an exceptional support rate for case managers, because at the end of the day, case managers are compiling all this documentation, really navigating this complicated application process, and they have no ability to bill an exceptional rate for the exceptional services that they, provide to the individuals that they support. Next slide. Okay, so questions. I know I ran through that, and I'm happy to clear anything up with more detail, and I can provide unlimited cost analysis to you all. So yeah, any questions?
Thank you, Amy. I have a question. So when we talk about exceptional support services reimbursement, is there an enhanced federal match for these exceptional rates?
So we get the same federal match, but something we might want to keep in mind here is that our SPL providers pay a provider tax at 5.5% of gross receipts yearly. So when those gross receipts, and we pull down federal match dollars from that provider tax. So when our gross receipts increase from SPL providers, they pay more in taxes. When SPL providers pay more in taxes, we get more federal money.
Okay, I think that's very interesting. One of the things I like about your presentation is I like how you have the recommendations on the back, because I think that, this is kind of the beginning of the conversation, even though the conversation has been ongoing for years and years. And I think when we have the opportunities to make, progress in this space, we also have to keep in mind that, I think the cabinet has given every indication that they're open to these conversations too, which I think is very encouraging. But they've been a tiny bit sidetracked, I think, with all of this pandemic nonsense that we're unfortunately going through. So I think as we continue this conversation, a lot of it is going to be kind of bandwidth is what all of the individuals can handle. But just because I think we're presented with bandwidth challenges doesn't mean that we still don't have opportunities to create a more conducive space to those who are reliant on these exceptional support services. And so I really appreciate your testimony, and I also know that we will engage you further in a lot of these conversations. I don't know, does the committee, anybody have any questions for Amy before we wrap it up with our closing comments? Okay. I hear silence. I hear crickets. So we may be nearing the end of this. I have been told that I'm supposed to make a couple of closing statements. And first is, any members need to be added to the attendance roll call? Anyone? Okay, invite members to submit suggestions for agenda items, either topics or presenters. And if we could get those to Chris on the LRC staff, that would be great. And so anybody on this call that was noodling on something that we discussed or wants to expound upon anything that we discussed, please let us know because we're open to it. And I just want to remind everybody to turn in their travel vouchers. And our next meeting for the Exceptional Support Waiver Services Task Force is Monday, August 25th at 3 o'clock. All right, so I guess if there's no objections, we are adjourned.
There's also something, that is in your comments, that I had written, if somebody would want to, answer, talk about that. It's pretty long, I apologize.
Oh, okay, well, hold on, Shauna, let me see. Hey, that is a little long. So what I'm going to do is I'm going to go ahead and have someone respond back to you since we have 1 minute left. And so how about that? We have your contact. So I'll circle back with you privately and we'll get you some answers on that. Does that sound good?
Okay,
Okay. Thank you.
you have my email, correct?
Yes, they said they have your email.
Okay.
All right, we'll get back in touch. Thank you. All right.